Welcome to this afternoon panel on mother and child care. First of all, I would like to thank you all for being present here at this time, and also with the fact of its being online participation. It's 6 o'clock in the afternoon. I'm sure that you've all had a very intense working day. So, well, I hope that in the social room you were able to take full advantage of the exercise that our colleagues of the organizing committee in Navarra prepared for us so that we could stretch our legs and get activity going again. In this panel presentation, we have 10 speakers, and introductions will be, well, one after the other. I'll be introducing each one with name and surnames, and then they themselves will say what the title of their presentation is. They can tell us where they work if they so like, and we will end, and all the questions and answers will come at the end, okay? Questions, let me remind you, should be done using the question and answer function that you have down in the menu bar at the bottom of the screen. Well, I think we're going to go on now to the first speaker, who is Pilar Rodríguez Soberado. So you have the floor, Pilar. Please share your screen with us, and you have the floor. Good afternoon. First of all, I would like to say thank you to the organizing committee for having organized this, and the scientific committee as well for having done such good work and allow me to be here with so many colleagues talking about this multi-center study about satisfaction and compliance perceived by lactating mothers and the promotion of breastfeeding. I've been told I don't have much time, so because of this, I will only be giving you some results of the study. The initiative for the analysis of fostering breastfeeding and seeing what the different guidelines are, well, have been working for a long time. And indeed, I think there's no health professional that wouldn't promote breastfeeding. But of course, we don't know what mothers think about the different initiatives, and we don't know the satisfaction of mothers with the different programs and initiatives. And that was the root of everything in our work. We wanted to find out about the satisfaction of lactating mothers and about care for the promotion of breastfeeding and the compliance perceived to follow the recommendations of the guide on breastfeeding. Ours is a descriptive study that is transversal. It's multi-center. It took place in 9 hospitals in different places, all of them with excellency programs for breastfeeding. We have a sample of 2,475 women with a confidence interval of 95%. The sample is proportional to the number of births taking place in the hospitals in 2017, the year of the study. So then the sample was taken consecutively from the beginning, the start of 2018, and in the proportions that had to tally ending in June 2019. Inclusion criteria: having started breastfeeding during hospital stay, single partum, absence of abnormalities, birth weight more than 2.5 kilos, APGAR score 5 at 5 minutes or more, and discharge of the baby at the same time as the mother. And then we didn't include women that were illiterate, with language problems, cognitive or mental deficit, or with a separation of mother and child. Those were excluded. Then this is a self-administered survey with 32 items that include, well, social and demographic questions, mother and child health, and also includes comments on professionals, also recommendations of the guideline on the basis, of course, of the perception of these women about the indications that they receive. And I'm sure, well, that you can see them. It's information about breastfeeding, then the breastfeeding support groups, skin-to-skin contact, education and support with the technique and maternal and child care, type of nutrition and supplements, and then also joint living. There were 5 questions as well that had to do with maternal satisfaction, one for each one of the different blocks, and with a Likert scale from 1 to 6. Before that, of course, there's preparation of the survey to analyze the complexity and the utility of the tool. And then there has to be consensus with the people in the research group, with the people in each hospital as to how this survey is going to be given. The questionnaire is given to mothers and they self-administer. It is voluntary and they had to place it in a special box. We had numeric codes both per hospital, per patient. So that means that there is a 100% guarantee of anonymity. Then descriptive analysis is followed with quantitative and qualitative variables. There is a variable created, which is a high satisfaction variable when the satisfaction questions are answered at more than 5 points or 5. And there is also an association established between satisfaction of mothers in each one of the theme groups with demographic and mother and child health variables. So all in all, we got 2,397 on average women answering 32.3 years of age. More than a third of the women declared that they had university studies and 50% were employed in different companies. More than half already had the children and nearly 90% had breastfed. According to type of birth, 22.7% cesarean section, 39.4 weeks gestational age on average, and weight between 3.316 grams. A very important factor to take into account is that 77.5% of the babies born were being breastfed only on the first day. Here you see compliance of recommendations, but always perceived by the mothers, the lactating mothers. And here we see first block about the information they were given on breastfeeding and the different interventions when they were told about breastfeeding, the importance of breastfeeding, and how to find support groups, the fact of being together. And this indeed, had 74.8% on average. Then second block, all the indications that have to do with skin-to-skin contact. And these are three main indications. Here, the compliance is between 80 and 90%. Third theme block about technique, interventions, and support for better breastfeeding. Compliance here is pretty unequal. We see this scattering. There are interventions with compliance over 88%. For example, having the help of a professional and the help of a professional for breastfeeding, but then interventions with the compliance that's even less than 40%. And I don't know. So that and this had to do with the signs of satisfaction coming from the baby. Then, remember, it's compliance, and this has to do with these different perceptions of mothers. Here, we were told that 30-odd% of the children born received a supplement, and very often it was because because the mothers asked for this supplement. As to separation, mother baby, quite a high percentage were separated, and mothers don't get the information as to what they can request. Another very important thing to take into account is that the doubts of mothers were solved in 87.5% of the cases. If to this you add that some of the mothers said that after training they had no doubt whatsoever, we believe that this result has to be taken into account. In this slide here, we see the table of maternal satisfaction in each one of the different theme subject blocks, and then the high satisfaction. Remember when the score was more than 5 or more than 5. As to the skin-to-skin contact, here we see the highest satisfaction. It's 96.89 of high satisfaction variable, and also in the average. And then it's the highest, in fact, of all the blocks. Then we have the administration of supplements. This has the lowest score of satisfaction. Here you see in red 72.28%. However, there is, a high satisfaction all in all. As to the bivariant analysis and level of satisfaction with social and demographic and health variables of the mother, well, according to these data, they're statistically significant. Let me point out the most important. Regarding mothers with university studies, they had less satisfaction as to information about breastfeeding and support and help with the technique and administration of supplements. According to age, women that were older were less satisfied as to the information received. And as regards work, women working not self-employed and also self-employed but working outside the home are not as satisfied versus women unemployed regarding the information on breastfeeding they got. And then finally, where there are some significant differences is in the block of according to the type of birth. Women who'd gone through a C-section had lower levels of satisfaction compared to those not with C-section. Something interesting as well is that small hospitals, that is those with less than 1,300 partum per year, have higher levels of satisfaction. You have 1 minute left, Pilar. Okay, yes, thank you. So anyway, this is, they are happier and in all fronts. So now coming to the end, we say that our study has allowed us to see that indeed the compliance to recommendations as to breastfeeding according to the mothers is good. The levels of satisfaction of these mothers is high with the care received, and the compliance regarding breastfeeding is pretty high. It's close on to the standards of YAM, and it's much higher than other studies that we have in our environment. And now finally, coming to the end, let me say that the implementation of such analysis is very important because the promotion of breastfeeding and analyzing satisfaction will allow us to get international standards and will also allow us to standardize many things. It's super important to analyze satisfaction of mothers with quality statistical tools. You have to end, Pilar. And that means that users, all in all, will be better. It means that quality information can be conveyed and that we can continue this way. Thank you to the mothers who collaborated with us. Thank you to the nurses as well who collaborated. Thank you. Thank you, Pilar. So, please stop your microphone and your screen. Yes, you've stopped it. We go next now to Alba Cebrián Jiménez. Hi, good afternoon. You have the floor. I'm sorry, I've got some problems I didn't have before with sharing my presentation. Yes, please try again. And if you have difficulties and you, well, we could actually go to the end. Yes, just a minute, please. Can you see? No, I'm afraid we can't, no. No, we can't see you either. Listen, you have to press the green button of sharing the screen. Now we see you. Now that green button at the bottom of your menu, where your menu bar is. Yeah, but I'm seeing something that's basic and I don't know what it means. Now you're sharing your screen. Great. It's starting. Very good. But now what we see is your access to the conference. Yes, now your desktop. Can you see now? Yes, now. Now, lovely. Okay, my apologies, I'm sorry. Yes, you have the floor. Alba. Thank you, thank you. I'm Alba Cebrián. I'm a doctor in the Nursing Sciences program of the Castellón Jaume I University, and I want to talk about our work on breastfeeding and educational intervention for schools. So, understanding the framework of schools as an ideal place to stress how important it is to have breastfeeding for better health of children and understanding the need of trying to increase the rate of breastfeeding at least 50% in the first 6 months of life, which is what the WHO is recommending. Well, We were especially interested in carrying out a project in which we could work in all different social layers. The idea was to assess the effectiveness as regards knowledge about breastfeeding in education. So we addressed this to primary education children in third and fourth year, so the ages of 7 and 8. Well, the design of the methodology was quasi-experimental. We worked in our town, Castellón, with special sampling, and we used a questionnaire that had 12 items. We analyzed social and demographic variables and also their answers with descriptive technique. And then we had univariant and multivariant methods to see the significance of the answers. As to results, well, all in all, 44, we had only 2 dropouts, but 86.36% yes had been breastfed as a child, and on average the pre-intervention questionnaire was 5.02, and after the intervention this went up to 0.27 over 10. So we can really say with a confidence of more than 95% that there are statistically significant differences in pre and post intervention answers. All the questions were statistically significant as regards the percentage of getting the right answer, and it was less in pre intervention questions. And so all the children, had good levels of information, but that improved after. So as to post-test qualification according to social and demographic variables that, as I say, we were very interested in, didn't really give us statistically significant differences. So what we were most interested in out of this study is the educational intervention about breastfeeding. And yeah, we discovered it's effective in the children learn the acquired knowledge. We cannot really say there's a relationship between the result of some social and demographic variables that we had anticipated. But however, yes, there are some initiatives like ours in the literature. And I mean, in Leicester, for example, the National Health, the NHS in the UK, and more recently in Croatia, they have also a very interesting study similar to ours. And also here in Spain, in Gibraltar, in Andalusia, a similar study was carried out. All these initiatives are based on educational interventions, and they all show very satisfactory results as to the level of knowledge of boys and girls about breastfeeding. So our study then, well, of course, had its own limitations. First and foremost, the fact that we didn't have all that much time, and we had to wait a lot to get the authorizations to actually go to the state schools in Castellón. It was difficult from the legal point of view. Secondly, only 1 out of the 11 schools invited accepted to participate, and that's why we had to do the special sampling technique to make it representative. And this legal issue is something we didn't expect, and it was quite problematic. Then, as to conclusions, well, I said so. The intervention has, yes, been very effective. We insist in as regards the acquisition of related knowledge, but we can't say that the social and demographic variables analyzed exert an influence on the different results. But evidence is telling us that the promotion of health at school can significantly improve the acquisition of healthy habits, and breastfeeding happens in adult ages. But however, it's very important that boys and girls acquire knowledge early about breastfeeding. And from the standpoint of normalizing and making breastfeeding visible in all different social groups, this could really help improve rates and reduce the abandoning of breastfeeding. So we suggest development of a unified educational program on breastfeeding addressed to young primary schoolers. And this could be developed. It means a new emerging figure that would be the social nurse or school nurse. So thank you very much indeed. It's been a pleasure to share this with you, and all the best. Thank you. Thank you, Alba, and thank you for respecting your time so well. Next, we give the floor to Serafín Fernández Salazar. You have the floor, Serafín. Please connect your video and share your screen with us. Hi, hello. Can you hear me? Yes, perfectly well. Super. Let me share the screen. Can you confirm you see the screen? Yes, absolutely. Lovely. Well, I'm Serafín. I'm a nurse. I currently work in Andalusia, in the south of Spain, in the public health service. And my presentation is about perceived barriers in the implementation of a clinical practice guide for breastfeeding through the BPSO program. My presentation is part of the PhD of the first author, who is David Arillo. Before I start with any conflicts of interest, I want to add to the congratulations. I mean, it's great that this is happening, and thank you to the Investen human team for giving us all the chance, despite difficult times and circumstances. It's brilliant that we can come together and talk of care beyond the situation we're living with the pandemic. So really, thank you from the heart for making this huge effort. Regarding conflict of interest, well, none whatsoever. We are a research team, and all this was passed by the research committee of our regional government. Regarding breastfeeding, well, there's not much to say. I mean, we are all professionals. Nothing much to introduce, but yes, I can talk about barriers encountered in the literature, barriers that have to do with the implementation of guidelines that have to do with breastfeeding. Up till now, not all that many studies are there that refer to breastfeeding specifically. So that's why the subject or the goal of our work was to define these barriers that are identified both by managers and professionals involved in the implementation of these guidelines and the sustainability of a program like this that wants to foster mid and long-term breastfeeding. For this, we designed a qualitative research program in a 300-bed hospital in this Murcia, Andalusia region. And this went on from 2012 to 2015. In 2015, the hospital was finally certified as a BPSO hospital. And we started the sustainability stage. Then, well, there were managers, nurses, monitors, pediatricians involved in the study. Then as to dimension, well, there are 4 dimensions to the methodology. 1, the lack of resources and adaptation to resources. 2nd, where, who, how. 3, the lack of dissemination and scope of the project. And then 4, the mother and her environment. As to the way we obtained data, we had semi-structured interviews going on between the months of May and August 2017. And with the persons participating, we would determine the day and time when the interviews would take place. Regarding analysis, we used a script of questions about difficulties and barriers that they encountered. Then we defined the criterion of saturation to see or to establish the number of persons. And then there are 6 steps. All this had a specific software, MaxQDA 12. And then coding of subjects and sub-subjects were also agreed upon by all researchers. 18 people participated, and as I said, there were 4 different dimensions. In each one of these dimensions, you see a brief description of the main results and, well, some little sentences stated by the persons interviewed. As to the lack of resources, that dimension, well, lack of human, material, and especially economic resources. And this is mentioned not only when talking about the implementation of a guideline like this one, but it's also something common to the implementation of other guidelines. It's the lack of time. There's no time. Wait, let me move this. Yeah, okay. So more specifically, one of the persons interviewed said, well, because of course we didn't have a lot of structure or resources to do this, so it was semi-structured and we adapted to what we had. So then I think we could talk about economic resources lacking, and somebody else was saying, and it's important, the lack of staff, but it's not so much the lack of staff, but rather the lack of time. Then as to where, who, and how, well, the results align, and it has to do with the place where the implementation takes place, the features of those who are in charge, and the relationships between these people that are clinical in their profession see the responsibility of breastfeeding in a different way. But this is, well, this was quite a novelty. Most think that the protagonism in breastfeeding is of the midwife. And this was something that came as something new because of the ambiguous role attributed to the midwife, and we'll see that later on. And then as well, there is, well, activities that are not purely clinical and resistance to change when it's the idea is to apply activities of promoting health. A person said to us, this is not only the midwife, it's also nurses. Somebody said, evidence? What's evidence? If we've always breastfed this way and nothing has ever happened, no kid ever died breastfeeding. Then as to the scope and the dissemination, well, a number of managers and clinicians say that dissemination has to be improved. Specifically, managers say that all this is pretty complex and that a lot of work has been done without obtaining good results. Somebody in one of the interviews said, well, this was done very slowly. I think that some people haven't even realized that this has happened. And maybe, I don't know, they wanted to do that not to be too visible. Or another person interviewed said, why? Well, yes, it's been worked on in primary care, but we've not been able to make this happen elsewhere. As to the dimension of mothers and their environment, the conclusion is that there's a lack of preparation before labor, and this because of all the resources. But the feeling of the mothers is this, that there's a lack of preparation, and they identify a negative influence of the close family and also previous decision about breastfeeding. One said to us, it's important that healthcare centers are active and that mothers come along with some sort of knowledge, but really the roles of mothers-in-law and grandmothers has a huge influence, and that makes life very difficult for future mothers. So there's this incredible influence of the family environment. Then somebody else says, once the awareness of people has changed completely, everything will be easy, and now it's too difficult. About discussion, well, this research program has identified a number of barriers, definitely, seen by professionals and managers. And as we know, these are solid barriers when you talk about implementation of a guideline. As has been shown in previous studies, we have to be aware of the fact that you have to make professionals have time to be able to invest in these programs. But there are also other new barriers that hadn't been described in international literature, such as I said before, this ambivalent or ambiguous role of midwives. Because on the one hand, midwives are seen by professionals as something very important when we talk about breastfeeding, because they promote breastfeeding, they do the follow-up. But then you have to see as well that in some cases, midwives were seen in inverted commas as something negative, because the perception is that if the midwife is there, the other healthcare professionals don't become involved in breastfeeding because they leave it all in the hands of the midwife. Regarding implications for practice, well, the effort to promote this implementation program has to be ongoing, and the extension to primary care services has to be a priority. And we should go more deeply into the interpretation of beliefs and behaviors of mothers and their family environment in these social contexts. And that's all. Thank you very much indeed for giving these minutes to listening to me. Thank you.
Thank you, Serafín. So you've stopped sharing the video, and now we will move on to María del Rosario Martínez Olivas. Hello, good afternoon. Can you share your screen, please?
¿Ahora?
Can you see it now? Yes, perfect. Thank you. Yes, good afternoon. I'm going to speak of the results of implementing the guides for best practice in breastfeeding in 5 pilot health pilot healthcare centers in Albacete. The authors, these are our conflicts of interest. We have no conflicts of interest. Different organizations recognize breastfeeding as the best way of feeding children in the first stages of their lives, with uncountable advantages for the physical, emotional health of the baby and mother. And not doing this is an important risk factor. Breastfeeding is perhaps the healthcare intervention that with the least economic costs achieves most benefits for the health, but there's no official monitoring service. The surveys come from different surveys. Less than half of the babies born in the world are in the first 30 minutes placed on their mother's breast. Worldwide, only 40% of minors of 6 months are breastfed. So because of all this, because of the best practices, guidelines are useful for the improvement of clinical practice and the health results, the Association Albacete decided to join the BPSO of the Ontario Nurses, Registered Nurses Association. In 2017, we started implementing the best practice guideline on breastfeeding in primary and generalized healthcare services. We wanted to assess the implementation and results of these guidelines on breastfeeding in 5 centers in Albacete. This is a quasi-experimental pre- and post-implantation study in primary healthcare. The population were children and mothers in those centers. It was implemented in. The sample were the children visited in nursing and pediatric services on the days established in the program. Inclusion criteria of babies born from a single birth to term without severe abnormalities, more than 2.5 kilo, Apgar 5 at 5 minutes, discharged with a mother, excluding those visited with administrative purposes or visited in the ER. This was a study done in December 2016. In the beginning of 2019, with the implementation of the guidelines, we started gathering data. For the implementation process, we followed the methodology established by the centers, compromised, with a multidisciplinary team led by nurses to select recommendations to be implemented, adapting different protocols and registers, preparing the training material for the mothers and relatives, training professionals, which is one of the most important phases, monitoring and assessing results, which has allowed us to detect areas for improvement and incorporate changes. In the study, we have 2 variables to assess. On the one hand, processes, including interventions of nurses and midwives with data on assessment, education, prenatally, on breastfeeding, and the other was variables of results on mothers and children, including the types of breastfeeding, 24 hours pre-discharge, total time of breastfeeding in days in which it was exclusively breastfed. The source of information was using a database of assessment of the program XXIV. I have to say that all the data have been anonymous, and the statistical analysis SPSSV.22, an analysis by variant according to the nature of the cases. And these are the results. We included in the study 1,865 lactating mothers. The average age was 33.06 years. All the variables have reached high level of implantation, but we have to highlight that the prenatal assessment was not done, and it increased up to 61.2%, which is statistically significant. Prenatal education did not undergo great changes, and the postnatal assessment and education have increased significantly, showing great effectiveness in the implementation of the guideline, and professionals have incorporated it in their daily work. The results variables, the average time of breastfeeding was 140 days, and the average time that the baby got exclusively breast milk was 81 days. But there's great variability. Children who had no mother's milk and others that had it until 2 years. Comparing pre and post implantation measurements, there's a decrease of artificial or formula milk, an increase of exclusive breast milk from the moment of discharge, 2-3 days. The situation of continuity of breastfeeding at 6 months was about 60%, doubling the national figures we have available. The situation of we have to highlight the number of children with exclusively breastfed. On the other hand, the percentage of the beginning of breastfeeding has decreased. We have 18.8% in older than 2 years, less than 3 months, 14.9%. Concluding, there's a high level of implementation of all the recommendations of the guidelines on best practices, and the baseline results have improved, increasing the amount of cases of breastfeeding in a high percentage of children, exceeding the data we find in Spain and the goals of the WHO of 50% by 2025. The implementation of these guidelines have unified the criteria between professionals, improving the registers and improving the planning of interventions, so it is applicable in the clinical practice of professionals. And I will leave you with the website of our hospital, where you can find the information material in case you want to consult with it. And I want to thank you for your attention and all the colleagues who have worked on the data gathering and in the preparation of the study. Thank you. Thank you, María del Rosario. Next, Jennifer Araque Garcia. We are doing very well time-wise. All the speakers are being very timely, so we might have some time for debate after. Rosario, can you share your screen? Oh, Jennifer, yes. Apologies, yes. Good afternoon. Firstly, I want to thank the Scientific and Organizing Committee for giving me the chance to present this paper. I'm a nurse of La Paz University Hospital, nursing supervisor, associate professor from the School of Medicine in the Autonomous University of Madrid. I'm also undertaking my PhD studies. I'm going to speak of an online consultation of nursing for the continuity and success of breastfeeding. This is what I will speak about, starting with some context to begin with. Breastfeeding is the best way, according to the WHO, to give children the nutrients they need for healthy development. In the past years, several research papers have shown that exclusive breastfeeding brings benefits for the newborn and the mother in the short and long-term basis, and also in a community level. The WHO and healthcare associations like the Spanish Pediatric Society recommend exclusively breastfeeding in the first months of life of the baby, and complementary food in the following months, continuing up to 2 years or more. Following the latest data published in the National Statistics Institute. In the first 3 months of life, in the first 6 weeks of life, babies, 68% of the babies are breastfed. At 3 months, 52%. At 6 months, 24.7 only. The general goal of the research is to assess the efficacy of an online follow-up through the computer platform Red Synapses to increase the rate of cases of breastfeeding in the first month postpartum. So we wanted to analyze the needs of the mothers, determine if the online consultation would decrease complications with breastfeeding, if consultation would overcome the doubts on puerperium and the newborn, and to assess the level of satisfaction. The type of study is quantitative, experimental, controlled, and randomized. The sample size is 90 mothers with a confidence interval of 95%. This has been based on the analysis of studies with similar object and characteristics. The participants were from the hospital of La Paz with no selection method. It was just voluntary participants we included, so long as they observed the inclusion criteria. Randomization, we had a control and intervention group following a list of randomization prepared by a program of pseudo-random numbers. Concerning the design and procedure, the control group went on with the usual follow-up by primary care. In the first month postpartum, they will be sent questionnaires 15 and 30 days after, and they will be told about the finalization of the study after. But the intervention group will have the regular follow-up in primary care and online follow-up through the Synapses network. Prior to this, they've been trained on the platform, how to move around, and the message system. In the first month postpartum, they will get relevant documents on breastfeeding and the taking care of the newborn, like adapting advice, things on breastfeeding, colics, and the storage of milk. The questionnaires will be sent at 15 and 30 days. In the first month postpartum, they will have their questions answered through the platform. Questionnaires will be received, and they will be told about the finalization of the study and satisfaction survey. Variables of the study, 3 great blocks. One of them, socio-demographic, including age, studies, whether they are married or not, the labor situation, and others. Other independent variables, including the Red Synapses platform. And a third group of variables depending on the study, the needs at the beginning of breastfeeding, the complications of breastfeeding, and the discontinuation, and the level of satisfaction with the platform. The gathering of data has been done through surveys and questionnaires, a demographic survey, the Latch score on breastfeeding, BSESSF score, and the questionnaire on satisfaction on the platform. Descriptive analysis shows that 70% of the mothers are between 30 to 40 years of age, 94.5 with a partner, 72.6 with university training. 70% of the sample firstborn, 30% remaining had breastfed in the previous pregnancy in 86% of the cases. 80% are European, and work-wise, 78% work for a company. With these epidemiological data are representative of the sample. The only variable is nationality, significant. We have control group, 85% are from South America, and the intervention group, 76% were European. In the study, some of the participants were lost because, among other reasons, they had discontinued breastfeeding. 33.3% but discontinued in the intervention, much less. The dependent variables, we have to highlight that the statistical results showed no significant differences compared to latch score, but some of the variables of the BSESSF score did show an importance. To the question, my baby is taking enough milk? Here we have the results. To the question, in every turn, I think my breast is enough to feed my baby. 69.20% in the intervention group said always versus 30% in the control group. In the satisfaction survey, the question was, have your consultations been satisfactorily been replied? 97% said yes, and the remaining said no. The intervention group were asked about their scoring of the platform 0 to 10. 42.10 scored it 8, followed by 28.9 in the intervention group that scored 9. After the analysis of the results, we can say that women who are followed by the platform feel reassurance concerning the sufficient food their children are receiving, and so they remain with breastfeeding exclusively. In the platform, 95% considered that they had more knowledge on breastfeeding and caring of the newborn, and 87% would continue using the tool, having finalized the research study. According to the literature, the high rates of discontinuation has a high impact in society, negatively influencing in the mother and child. So the promotion and protection of breastfeeding is a European priority in healthcare. Puerperium is a period of great changes, requiring the support and attention of healthcare professionals throughout the whole process. So it is indispensable to have constant care, and ICTs offer many tools to achieve this goal. With the current situation with COVID-19, access to 2 minutes, yes, with less access to healthcare services, the use of these tools like Red Synapses foster the promotion and further use of breastfeeding. ICTs in healthcare, in the healthcare sphere, is not the future, it is the present. Thank you for your attention. Thank you, Jennifer. And next, we will give the floor to Teresa Cosella, who will speak in English.
Teresa, please.
Teresa, you have the floor.
Sorry, can you see my screen?
Yes.
Okay, thank you. Sorry, just give me a moment here. Okay, good. I'm not showing that it's showing. Are you sure you can see that?
Yeah.
Okay, good. Thank you. Okay, hello, my name is Teresa Cosella. I am a public health manager currently working in the emergency response for COVID-19 in Toronto, Canada. Thank you to the organizing committee, and I'm very honored to be presenting to you today on my Advanced Clinical Practice Fellowship project with the Registered Nurses Association of Ontario, or RNAO, in collaboration with York Region Public Health and Ryerson University. My project title is Public Health Nurses' Experiences of Implementing the Bristol Breastfeeding Assessment Tool, or BBAT, into practice. Before I begin, I would like to take this opportunity to acknowledge my fellowship primary mentor, Dr. Elaine Santamina, Associate Professor with Daphne Cockwell School of Nursing in Ryerson University, and also my mentorship team, Dr. Dawn Rose and Sherry Espen, also with Ryerson University, May Tao from Toronto Public Health, and Shelley Stalker and Anne Chinilio from York Region Public Health. Without them, I would not have been able to complete this very important work. Let's begin by understanding the concept of change. Stop for a moment and think about a recent change at your work. What was it like for you? This word cloud represents nurses' thoughts about change. It may be a challenge to do something differently, but through that challenge, there is growth. The purpose of my project was to evaluate the impact of the RNAO best practice guidelines implementation strategies on public health nurses' knowledge, skills, and experiences of using a validated breastfeeding assessment tool in a public health breastfeeding clinical setting. RNAO best practice guidelines, or BPGs, are evidence-based and assist healthcare providers to make decisions about their practice. They are supported by Health Canada and funded by the provincial government of Ontario. My project was focused on one recommendation of the breastfeeding BPG, which was to assess breastfeeding using a validated and reliable tool. We chose the Bristol Breastfeeding Assessment Tool, or BBAT, which objectively measures breastfeeding position, latch, suck, and swallow by providing a score that could be used for comparison and evaluation purposes. To provide an organizational context, York Region Public Health followed the principles of Lewin's change theory and was guided by the knowledge to action framework. My project focused on step 5, which is to monitor knowledge use and evaluate outcomes. The program evaluation methodology was created based on the Donabedian model of structure, process, and outcome. The outcome indicators were related to the public health nurses' experiences of implementing an assessment tool into their clinical practice. Data collection included chart audits, an online survey, focus groups, and telephone interviews. The study sample was 14 nurses working in the breastfeeding clinic at the time of the study. Chart audits revealed that almost 1,500 clients were assessed using the BBAT during the project timeline. The BBAT completion rate increased from 61% to almost 100% from initiation to the end of the study, which is approximately 8 months. Nurses related this increase to the most helpful implementation strategies of ongoing support and reminders from the breastfeeding BPG lead champion. Themes from focus groups and interviews were categorized according to structure, process, and outcome. Nurses identified supportive structures such as having breastfeeding BPG in place, integrating the BBAT into the existing data system, and having time to implement the change. Processes to support the change in practice included consistent training, ongoing support and communication from the BPG team, management, and others. The organizational culture of quality enabled and facilitated the practice improvements. In theming the outcomes of the nurses' experiences with implementing a new assessment tool, 3 categories were apparent. Nurses spoke about their competencies in evidence-based practice and their connection of the BBAT to their work that they had already been doing. They valued the autonomy in making evidence-informed decisions by critically reflecting on their use of a validated tool in practice. It is interesting to note that these themes are congruent with the elements of the self-determination theory. This word cloud represents the words most frequently used during the focus groups and interviews. Notice the importance of practice. One nurse stated, "I desire to do my job well. It, the BBAT, helped me to know another way of evaluating and categorizing what I see." The desire was to know if the BBAT improved client outcomes. Yet the project scope did not intend to explore the benefits to clients and any improvements to breastfeeding outcomes. An implication is to dig deeper to understand what truly drives and sustains BPG implementation in nursing practice. Nurses had the practice competencies and autonomy to make evidence-informed decisions about clients' care. However, we need to recognize the connection between the validity of a tool and its ability to make a difference to the client. Recommendations at a practice level are to use a theoretical lens, such as self-determination theory, for a deeper understanding of the factors which motivate and sustain practice change. At an organizational level, there is an opportunity to bridge the gap between hospital and community practice by collaboratively implementing a validated tool for referral purposes. Future research to measure the impact of implementing BPGs on client outcomes is worth exploring. Now, what about you? Have I inspired you to ask some critical questions about a change in your practice? Hopefully, I have motivated you to engage in lifelong learning for continuous improvements in nursing practice and client health outcomes. Thank you.
Thank you, Teresa. A continuación, damos paso a...
Next, we shall give the floor to Irene González Pérez. Hi, hello, good afternoon. Hello. Yes, please share your screen with us. Thank you. Before I begin, my thanks to the organizers for having given us the chance to meet, although it might be online, but that's better than nothing, definitely. And I will start by talking about, it's part of my PhD. It's a research program carried out in La Laguna University in Tenerife in the Canary Islands, and it's the health sciences doctoral program. And here, more specifically, I'm going to be talking about the results of effects on newborns when there is a proper partner program. I'd like to say, first of all, that the authors of this research have no interest conflict whatsoever. And we submitted this research to the ethics committee. First of all, let us talk about research and how do we define this program of labor. It's a pretty recent document in Spain, 2007, and it's quite, legal. But here, pregnant women determine, what their preferences are, their needs and wishes when they are going to actually have the baby. And whether they want epidural anesthesia, whether they don't, whether they want their partners in or not, all that is written down in document. And in the hospital center, this is usually given into the registry before the labor begins, or it is part of the mother's documentation, and she has to carry it with her at all times. It acts as informed consent, and it is a written document, but it has to be re-elaborated. It's a dynamic document, okay? So, and this has to happen as all this is happening, as the birth is proceeding, okay? Because there might be unexpected events happening, and it's also personal and unique, in the sense that there cannot be there might be pre-designed or semi-standardized programs, but they can't be, because any document that is a birth plan has to be specific for each person, and it's as official as an official document. This is what it looks like. As I say, since 2007, this is what you find when you peruse the document. And this is also a birth plan. It's valid. And this is yet another, as well as these are documents that are written and signed by the mother-to-be and the health team. Why a birth plan? Well, with the standardization of healthcare, the role not only of midwives, but also the role of users, in this case, the women in birth was actually lost in a way, and maternity suffered for it, because the role also of the nursing team, the role of the future mothers was changed, and it all became very patronizing, and the decisions were made only by the doctors, by the clinicians. Finally, there was the law of the patient's autonomy that was passed. And there they highlighted the importance of decision-making in maternity, which indeed required a section all on its own.
Sabe que existe evidencia científica y guías de práctica clínica que cuestan implementar en los servicios de obstetricia en muchísimos países, no solo en España. Y, perdón. Y además...
Is everything okay? I'm sorry, the sound wasn't working for a few minutes. We know that the importance of the psychological and emotional feelings of the pregnant woman must not be undervalued because it plays an important role in the results, both psychological and prenatal physical results. So then the research then focuses exactly on this, on analyzing this birth plan and see what the maternal satisfaction is and perinatal results. But more specifically for this presentation, we are going to be justifying only neonatal results. The hypothesis put forward, ad hoc hypothesis, is that the application of a birth plan can, in obstetric care, can improve results, neonatal results, and the goal is to analyze the effects of the presentation on a birth plan on neonatal results. For that, we designed a study, observational, descriptive study. Two groups were defined, some with and some without a birth plan. Subjects of study were the women who had birth in the University Canary Hospital during the project, May 2016 to May 2018, who complied with all inclusion criteria and accepted in a voluntary manner to participate in the study. Sample size, and then, well, all we had to do was gather data of clinical histories. And what we did realize was that well, in obstetrics and with maternity and the changes in law in Spain, the number of birth plans given in was very low, that people were actually not fulfilling and not giving in and not taking these birth plans to the registry. So we had to promote the plan to make sure that women knew that this birth plan existed so that they had access to the plan. And in that way, we guaranteed better results for everyone involved. So we talked with primary care colleagues, with midwives and those working in the hospital, in this case, the Canary Hospital in Tenerife, who accepted to collaborate. And it was decided that they would promote this birth plan and they would explain it to women expecting, and they would tell them how this could mean better results. So here are the inclusion criteria: to be a woman more than 18, then to have actually had a baby in this Canary Hospital during recruitment, and also to accept participating. And the exclusion criteria, the typical. Then variables of the study, well, neonatal that we analyzed were the newborn's weight, set all the percentages, APGAR at 1 and 5 minutes, umbilical pH, neonatal resuscitation, going to the neonatal unit, and the time spent in this neonatal unit at the hospital. Then we analyzed data with Excel, and then we processed and analyzed with the SPSS. First, a descriptive analysis of the total sample, different according to variables, of course, well, histograms or Kolmogorov-Smirnov test. And then we compared groups, and the significance was, well, according to the typical variables, it was more than 0.05, and then we also analyzed with other techniques. These are the results that we obtained. Neonatal results, I insist, and in the first column, in descriptive analysis, you see by group, and we see that there was no statistical significance between both groups. So we coincided in that this birth plan regarding neonatal results didn't show to change things at all. There is no statistical significance, so there is no difference in neonatal results. However, we do insist on the importance of the birth plan for a positive labor experience, and this is something stated by the Ministry of Health and Consumption and by WHO. And also, we believe that we require more research done analyzing the relationship between compliance with the birth plan, the degree of compliance, and perinatal results. And this basically is it. The conclusion of our research is, well, that there seems not to be, well, a significant relationship between having this birth plan or not as regards analyzed neonatal results so far. And finally, well, here you are. We want to highlight the fact that the power of a birth plan isn't the actual plan itself, not at all. That's a conflict in terms. I mean, a birth plan is simply the process of becoming educated about all your options, and it means empowering women, and it means that women then become active and more involved in all the possible decisions in something as important to them as the birth of their baby. That's all. Thank you very much indeed. Thank you. Thank you very much for your presentation. Next, we're going to be listening to Cecilia Triviño. Cecilia, you have the floor. Do share the screen with us, remember? Now. You have to unmute your microphone, please. We can't hear you. If I find you, I'll do it myself because we can't hear you. Yes. Now can you hear me? Yes. Okay, lovely. Now you can hear me. Yeah. You have the floor. Well, first of all, good afternoon, and thank you very much to the organizers for having made it possible that we're having the conference despite current circumstances. My presentation is about pain and how do you handle pain during labor, and this is an analysis previous to the implementation of the BPSO guideline, and this is in the Santa Lucía University Hospital. The authors that you have on the slide are people participating in the study, and well, none of them have any conflict of interest. Currently, the General University Santa Lucía Hospital is a candidate to become a center of excellence in the Best Practice Spotlight Organization program. In the coming months, the idea is to implement the guide for assessment and handling of pain in obstetrics. And because of this, we decided to do this research. And the information obtained is very useful because it gives us data that will be a reference to identify areas that can be improved upon regarding current medical practice before we implement the guideline. Furthermore, the sample size is quite substantial, and this makes results obtained become very relevant indeed. The goal of the study was to analyze the type of anesthesia and measures for improving pain and used in the Santa Lucía University Hospital. This was a descriptive statistical study analyzing different measures applied, pharmacological and non-pharmacological, that are written in the birth registries available from the years 2015 to 2019. Then we used SPSS version 24 to analyze, to statistically analyze results obtained. For descriptive analyses and normalcy of quantitative variables, we use the Kolmogorov-Smirnov test. To determine the association between qualitative variables, we use the X-square of Pearson. And to determine association between not normal quantitative variables and polycotomic qualitative variables, we use Kruskal-Wallis and correction of Bonferroni for multiple comparisons. And we used an alpha significance level of 0.05. Total sample, 10,909 births. Average age of the women of the sample, 33.4 years of age. As to the type of analgesia, well, you see epidural, 61%. That was the most used, with 61%, and it's the greater part of the sample. Then we also have women that opted not to have any kind of anesthesia, 16.5%, then lumbar area anesthesia and local anesthesia, 11%. rest of persons analyzed, general anesthesia, nitrous oxide, sedation, and massage had a very low incidence between 0 and 1%. As to the kind of analgesia used according to age, we obtained a non-normal distribution, excepting the anesthesia with a statistical significance for women on average 35 years of age. The most used anesthesia according to the country of origin of the women shows that 70% of Spanish women decide to have epidural analgesia. 34.6% of Moroccan women decided to have the baby with no analgesia. And the relationship between analgesia and episiotomy, it was seen that 84.1% of the episiotomies had happened with epidural analgesia, and only 2.6% in the case of women that gave birth with no analgesia. As has been mentioned, the greater percentage of women that had the baby with no analgesia was mostly of Moroccan origin. And on the basis of the literature we consulted, among Spanish women, it seems that, well, there's a language barrier that is having an influence here. And we saw that the non-pharmacological methods to make pain less during partum are better for handling pain and have very few side effects. But we have scant available evidence for this. Pharmacological methods to alleviate pain during birth are efficacious, although there are more side effects compared with others. This is the case of epidural analgesia that shows more instrumented births and more complications. So all in all, in the Santa Lucía University Hospital, epidural analgesia is the most used method in order to have less pain during labor, and it's related as well to greater rates of intervention. Non-pharmacological methods are not really used, and patients that don't use anything for pain during partum, during labor, are usually of Moroccan origin, and this might be related to a language barrier. So that's why the BPSO guideline of assessment and handling of pain in obstetrics has considered necessary to foster the non-pharmacological method use in order to improve this pain during birth, to foster new studies regarding possible side and adverse effects of non-pharmacological methods, and to prevent consequences of some pharmacological methods to reduce pain, the most used. This is a case of this high episiotomy in the case of epidural anesthesia. And that's all. Thank you very much. Thank you. Thank you. Well, I think we told you had to speak so fast that you're all being excellent about time. Not only excellent, but you're not even using up all the time that each one of you had allotted. That's excellent. We'll have more time for Q&A later on. The floor goes now to Marina Augusto Satue. Marina, you have the floor. Remember, unmute and share your screen, please. Full screen, please.
Espera, que voy a mirar a ver si...
Let me see if I can fix this. Can you hear me? Yes, absolutely. We can hear you very well. We can't really see you. Yeah, it's all perfect. Yeah, okay, yes, we can see you, sorry. That's perfect. Please, go ahead. You have the floor. Thank you, good afternoon. I'm Marina Augusto. I'm a nurse in the Barbastro Hospital. Let me start my presentation by saying, first of all, that in 1742, we know about the first acknowledged episiotomy. And after that, we see that during, well, the years from 1999 to the year 2000, in Spain, the rate of episiotomies was 77%. But in 1996, the WHO stated that there are no benefits associated to episiotomy. As well as this, there's a European comparative study from 2004 to 2010, where we see that Spain has the greatest rate of episiotomy in Europe. Because of this high rate of episiotomies, the motivation of our research has been to look for new methods to reduce episiotomies. And so next, I'll see whether perineal massage and EPI-NO has any effectiveness or not. The research question was, what's the effect of perineal massage and epi-no in the prevention of episiotomy or perineal tear and the integrity of the perineal zone? We wanted to know the relation of its effectiveness with perineal traumatism, to know the benefits both of epi-no and perineal massage, and describe the relationship between incidence of tears, episiotomy, and an intact perineum. The methodology followed in this project has been, first of all, to establish inclusion criteria according to time. So we shall only include articles published in the last 10 years. Language, so Catalan, Spanish, English, Portuguese, and French. And types of research or types of study included for my research have been controlled, randomly controlled essays, systematic revisions, and observational studies, and accessibility, well, all those that were free of charge. Then, for the search, one has to establish keywords first of all, and after that you go to descriptors in order to have a more effective search in these databases. Databases that participated in the research have been Padme, Witten, and Science Direct. First of all, 82 articles came up, but I ruled out 6 of them because they were all repeated and here I used Mendeley, which is a very good bibliographic manager, and this was done automatically. And finally, I ended up with 12 articles, and these were methodologically okay, and this was done through the CASPE tool. Results obtained upon perusing these articles are that there is a reduction of tears and episiotomies in the intervention group, that is, mothers that use both techniques, then a reduction of pain, reduction of use of postpartum analgesia, increase of a possibility of having an intact perineum, and most especially very important that the perineal massage has to take place as of the 34th week pregnancy and epi-no after week 37. For the effectiveness of epi-no to be correct, you must reach a circumference of more than 20.8. So, group comparison was established with control and those with the different interventions. Perineal massage and EPI-NO, both techniques obtained good results, especially in the intervention group, which of course is the group of people using the technique. In perineal massage, as to tears, the intervention group has tear of 13.5% and the control group 29.5%. And in EPI-NO, in the group of tear, 61% and the control group 63%. So in general terms, we can highlight that the intervention group is much better or pretty much better than the control group. Both techniques, well, first, EPI-NO was created in 1999. It has to be used, as I said, as of week number 37. And as I said previously as well, for circumferences more than 20.8 centimeters. And perineal massage can be used as of week 34 during 5 to 15 minutes every day. And it introduces in the mother a previous knowledge of what labor can be. It reduces stress and it improves circulation. And both techniques have better vaginal and perineal dilation. Finally, conclusions of our research, well, to determine that episiotomy is not a technique that prevents perineal trauma. Techniques have to be carried out between 3rd and 6 weeks before labor. There are big differences between the intervention and control groups that we've seen previously that I showed you. And currently, there's a greater evidence, scientific evidence about perineal massage, more on this than EPI-NO. And finally, we determined the lack of evidence as regards effectiveness. That's why the recommendation is for future research on this technique. Thank you very much, and I hope that you liked it. Thank you. Thank you very much, Marina. Okay, lovely, super. You've stopped sharing your screen. Next, I'm afraid Esther just muted her microphone. Okay, muted again. I'm sorry, we're getting no sound from Esther.
No te escuchamos, Esther, ¿puede ser?
I'm sorry, Esther, we can't hear you. Yes, sorry. There's a war as to who silences who. I'm sorry. We were not coordinated. Well, as I was saying, yes. Okay, this is working fine now. So we only have one presentation to go, which is that of Pablo Rodríguez Coll. And Pablo, what language did you decide you would present in? Because the translators and the guests should know. In Spanish? Okay, lovely, fine. So, for the translators, indeed, well, this presentation had the title in English, but it's finally going to be given in Spanish. Burnout syndrome among midwives working in maternity hospitals in Barcelona. You have the floor.
Vale, ahora.
Okay. Good afternoon. I'm Pablo Rodríguez Coll. I'm the manager for the maternal and childcare area here in a hospital near Barcelona. And I also am part of the board of the Midwives Professional Association in Barcelona. The title and the presentation were in English because this is research that took place in 2017 about burnout syndrome in midwives in Barcelona, and why we did it in English. But considering that most of the participants here at the conference, I decided to speak in Spanish. And, well, because I know this translation, first of all, my thanks to the organizers and the scientific committee for having given us a chance to share our research with you all. And as well, or most especially, my thanks to the nursing school here in Barcelona for helping us out on all this. Authors have no conflict of interest. And let me tell you that nowadays we live in a society in which there's a new model of care. It's birth humanization. And this means that the woman is at the very center of care. This means that women are empowered regarding decision-making and regarding the decisions precisely that have to do with the birth process. And it increases, in a way, the work of those of us who work as midwives, because, of course, more care has to be given in a focused manner. On the other hand, we know as well that there's a delay in maternity, so it means that women, well, are mothers at a more advanced age. The average age for firstborn is between 38 and 40 years of age, and this means, of course, so this entails certain risk during pregnancies, such as diabetes, high blood pressure, and other related pathologies. All this means an increase in the work of midwives, and if we unite this to the lack of professionals, that is a problem, but not only during the pandemic, but I mean, we need many more midwives in hospitals, especially here in Catalonia, in the northeast of Spain. And, well, as this is the situation, it means that, well, we have to take care of quite a few women during not only active times, but also when we are in different shifts. And I mean, this one-to-one care is very difficult. So all these factors can eventually lead to the burnout syndrome amongst midwives. And what are the consequences of the burnout syndrome? Well, the scientific literature is telling us about many, but there are four that are most important. One is the abandoning the job, anxiety, depression. Also, well, the depression can actually mean also because of insomnia can get worse, and there's a higher predisposition to conflict among colleagues. But most especially, and I mention it again, there's this problem of insomnia. Yeah, I mean, the burnout is there. But what happens, it's just the fact that these people are not motivated to work and they cannot give good care to the women that they should be taking care of. So objectives, goals of our study, to describe the prevalence of burnout among midwives working in the 24 public maternity hospitals in Barcelona, or those hospitals that have some kind of an agreement with the health service. So that means they belong really to the Catalan Health Institute network. We wanted to identify the social and demographic features and the job features associated with this burnout syndrome. This is a cross-sectional descriptive study. Here we have used the questionnaire, Spanish Burnout Inventory. This is the instrument we used. And this is, a questionnaire created by a Spaniard, but it's international. It's a 20-item self-report questionnaire. And it's also for other professionals working with the public, like civil servants or teachers. We chose it because of this precisely, because, well, I guess that you know that the Maslow's burnout inventory is very, very much used, but one has to take into account this tool. 20 items. Likert scale of 5 points from 0, never, to 4, every day, measuring 4 subscales. First, psychological exhaustion, indolence, guilt, and enthusiasm towards the job. And furthermore, there was a survey included that we created contemplating professional and personal variables. The information was gathered from the 24 hospitals that participated in the study that I mentioned before, and during January to March 2017. Participants were selected by convenience sampling, and out of a total of registered midwives, that's 248, and out of this group, 122 midwives returned the online questionnaire, so response rate was 50.41%. As to recruitment, well, participants who met inclusion criteria, which I'll describe to you in greater detail in a moment, were invited to participate through a mailing list from every midwife supervisor. Inclusion criteria, well, being over the age of 18, to being a midwife working on labor wards in delivery room, to be able to understand Spanish, and to have a basic computer knowledge to be able to answer a survey online. Exclusion criteria, well, midwives working in community health centers, postnatal wards, or those working in private hospitals. Why? Because we considered that was different, very different, because you can't compare burnout between public and private hospitals. Results, well, most participants out of the 122 were women, 96.7%. Average age of participants, 40, pretty young, between 25 and 64 years of age. Standard deviation, 10.88. Then in descriptive results, we saw that 67% of the participants had a life partner, 55% had more than 10 years experience, 46% worked only on day shifts, not night shifts or mixed shifts, and 64% in their jobs were in charge, between 1 to 3 women per shift. As to prevalence of the burnout syndrome, none of the participants got a critical level considered by the questionnaire as the burnout itself, yes. So, but however, we did see, well, one participant that got a pretty high level, between 67 to 89 percentiles, and 30% that scored as medium burnout syndrome. It's important to highlight as well that both in the low and very low percentages, well, that's 70% of the participants all told. So these medium-high levels of burnout syndrome that we have described are significantly correlated with considering the job is stressful, with the marital status, when they attend more than 3 women per shift, the number of children, parity of the mothers, health status, and then having been on sick leave the year previous to the survey. We also could see that the burnout syndrome scores were higher in midwives having a life partner without children and in the age group from 36 to 64. Also those with less experience, that is those with either 1 to 5 years of experience. So that also had an influence. What are the conclusions of this study? Well, following or on the basis of the results, we see that midwives in Catalonia, a region that, as I said, is pretty difficult regarding midwives, don't have a burnout syndrome. However, 30% did score medium to high levels. Yes, you've been 9 minutes. Okay, sorry. Well, just let me give you the conclusion. So this questionnaire, we think, can make it better to treat the burnout syndrome and for midwives and researchers and, well, implications, well, of the study. We think we could improve or prevent this burnout syndrome with specific shifts, rotating shifts, combining senior and recently qualified midwives to reduce stress, and that this could be used and replicated in other settings, for example, in postnatal wards, also in private hospitals, and to compare results in order to eventually improve the quality of the service and also the care given to these people. Thank you.
Thank you, Pablo. Thank you. Well, I think we're doing very well time-wise, so as to have some time for debate and questions. We will have Silvia and Laura to ask the questions. Let me remind the participants, if you want to ask a question, you have the Q&A section and the bottom bar of the screen where you can ask your questions. Yes, we do. We have a question for Jennifer Araque. Do you have any follow-up data of breastfeeding during the pandemic? What's the efficacy of ICTs in this period concerning breastfeeding? Thank you for your question. During the pandemic, we've changed in the way in which we work in hospitals. In my hospital in La Paz, most women were discharged early, 24 hours after labor, and the midwife would go and visit them at their homes. Most consultations, when the midwives went to the homes, besides checking the newborns, many times they were asking about breastfeeding. Previously, patients would stay 48 hours in the hospital minimum, and they constantly had expert healthcare professionals who would advise on breastfeeding. With the pandemic, the mothers and the babies were discharged as soon as possible for safety reasons. There was also a cross-sectional study in the follow-up of gestating mothers after 28 weeks, and they were asked about the perception on the information they were getting about, among other things, breastfeeding. And 75.6% of these pregnant women said they had no information or recommendations on breastfeeding during the pandemic. So clearly, the situation is hindering that promotion of breastfeeding, and we are not taking full advantage of the tools available in this area. And our duty is to use all these tools so that the advances in breastfeeding keep moving forward, although the situation now is overwhelming, certainly. Thank you. Thank you, Jennifer. We've been asked that if there's a question addressed at someone, that person who is going to answer should please activate your camera so that we can see your faces as you are answering the question. Yes, I'm sorry, I just turned on the mic. Yes, of course. When we have to do many, many congresses online, we will all be super good at it. I don't know if there are any other questions. Silvia Laura, I have a question for Maria Rosario. Can we see, can you activate your camera, please? Yes, great. I know that the time you've been working and your project is quite recent. Could you share with the audience what you've done to work on that collaborative project between specialized and primary care? How have you organized the teams? How do you coordinate between the specialized and the primary healthcare teams? Maria del Rosario, can you turn on your mic and camera?
No sé si nos oye Rosario. ¿Nos oyes?
Can you hear us? Yes, yes, I can.
Vale, perfecto, gracias.
Bueno, pues vamos a ver. Es verdad que la guía está
It's
de...
true. The guidelines on breastfeeding took some time to implement. There's a greater number of services involved. We have, first, it was implemented in specialized service and obstetrics, delivery rooms, ICUs, in pediatrics, neonatal ICU, and then it was implemented in the healthcare centers. So all this takes to a series of meetings between the leaders of the guidelines and the managers of specialized care or primary care. And
pues es así un poco como se van
that's
coordinando.
basically how things take place. So far, there have been 2 assessments in specialized care, 1 in primary care. And there are 2 teams, and they just meet together every 6 months, I believe. I belong to the team of evaluators, and I don't know exactly about this, but basically it is how it works. And there's a working group that is multi-level, and that's it.
Gracias.
Muy bien, muchas gracias.
Thank you very much.
A ver, tenemos otra pregunta que nos formulan para Pablo Rodríguez. Y la pregunta es si a partir de los resultados de su investigación se han planteado intervenciones para mejorar el nivel de burnout de las matronas.
Hola, de nuevo. Vale, sí, pues quería comentaros que el estudio todavía no ha sido publicado, está en revisión por la...
The study has not been published yet. It's in the journal that we will publish it. We do have some measures we have considered in the next meetings of the Association of Midwives. We will agree on these together with experts on the matter, and we will try to do it through the initiatives. Among those measures, we have taking shifts or another improvement, for example, improvements in the organization on the shifts was which one of the things that the participants considered to be most important in terms of their work. But for the time being, we've not written down those measures. We have to agree them and work on them. If you'll allow me, I have a question for Teresa. And for Serafin as well. I'd like the 2 to say something. If I've understood well, you said one of the structural matters that you were counting on was the possibility of having time for that learning process, for that training, and for those activities related to the recommendations of the guidelines. And Serafin, who presented the work with the Renal guideline for breastfeeding, said the opposite precisely, that nurses and midwives manifested the lack of time as an essential element. Teresa, shall we start with you?
Actually, I do see it as the same and not opposite. The nurses did say that they needed the time in order to implement.
Okay.
Yes. So sorry if I was not clear on that.
No, seguramente no lo he entendido yo bien. Pero
No,
entonces,
I'm sure it was my misunderstanding, but then all the better, because the results in Canada and the results in Spain show the same patterns, this lack of time. Out of curiosity, and to give it some context, I don't know if you could tell us a little, what are the ratio of nurse and patient in the places that you know, to know if it's a matter of time, because they are understaffed and the problem is like in Spain and in Canada, or rather is it very different?
So I'll give you, in terms of the context for our clinical setting, there are 14 nurses that were working at the time of the study, which was last year, 2019, from May to November. And that clinic, we had seen approximately 3,000 clients in that whole year, but during the time of the study, there were about 1,500 the completed assessment tools that were completed that time. So the amount of clinical experiences, it is quite a busy pace. However, we do have more time in the public health breastfeeding clinic setting compared to what nurses in the hospital would have. So in the nurses in the hospital using that BBAT tool, they only have like that 5 minutes, and then they're on to a number of other things. Whereas in a breastfeeding clinic setting, more in the public health context, we do spend a lot of time with that health teaching. So we use the BBAT, and then we look at, where does that mom need more care and more assistance, more health teaching, that sort of thing. So our goal is to improve breastfeeding outcomes. But unfortunately, with this study, it did not really measure that part of it. It was more about that nurse's experience in using that tool. So I'm not sure if that answers your question, but it is, we do have a lot of clients that we do see, but not as many as would be seen in a hospital setting.
Bien, ahora te doy paso, Serafín, pero...
Thank you. And now, Serafín, but to tell you a little bit, in Spain, we have many centers in the project of the BPSO, and it's a constant complaint. They say the organization does not give us time. And so sometimes I think it's good to know, it's reassuring to know that others are suffering from the same, it's not just us. Serafín, you have the floor. Yes, this lack of time, as we know, is one of the barriers, most frequent barriers when we speak of practice, evidence-based practice. You always hear this when you look at systematic reviews. It's always lack of knowledge, skills, and lack of time. Can you speak a little more slowly for the interpreters? Thank you. Yes, apologies. The interesting thing is that the research also contributes to the fact that professionals interviewed related this lack of time to the lack of staff. So if I had more staff, I would have time to do this. But there's another variable, which I also found very interesting, and that is the fact that breastfeeding should be associated to health promotion. And health promotion, there are some professionals that don't identify this as a clinical activity. It's a matter that if maybe I have time, if I give it enough attention, this vision we have that is focusing so much on disease makes it so that some professionals understand that health promotion is an activity that is of a second level. So added to that lack of time, because there are not enough professionals, means that in some services, breastfeeding is not fully implemented as it should be. And I suppose there are other variables that could continue with that debate. Serafín, as you were saying, I have a question, because when we now implement these characteristics, this doesn't involve the professionals, but rather all the service and all the professionals. So my question is, if this perception of barriers is the same amongst all professionals involved in the process. Well, Silvia, there are professional profiles that are identified by others as not involved. For example, gynecologists, pediatricians. When I was speaking of the results that the professional profile, the trending topic in breastfeeding is the midwife, makes it so that other profiles just see the midwife as the person who should be involved. And since they are there, I'll just remain aside. Instead of seeing it as an opportunity to see to have a midwife in your service, makes it like an obstacle for others to intervene. So it's very interesting, and it'll be interesting. It would be interesting to explore this and to do further research, how to incorporate that profile, because it's so very profile, but without leaving others aside or preventing others from not participating. I don't know if there are any other questions in the chat. Someone says, congratulations to all the speakers. I have a question for Pilar Rodriguez about the guidelines on breastfeeding. What's your learning from the standpoint for the implementation of clinicians on the one hand, and where would you focus the next research if you continue along these lines? I don't know if that will continue. I hope so, because it is a priority, because satisfaction of mothers changes. But having seen the results, I think we should focus on, as Serafin was saying, why is it that the promotion of activities of health, why don't we focus so much on this? Because having seen the results, we've seen we have no adherence for the mother to learn about the signs of satisfaction of a child after eating, other signs of hunger. No, we rather focus on placing the child and helping her place the child. And I think future research should find out why don't we do this. And perhaps it has to do with the lack of time. And I would also focus on something but that I would ask, why do we get so many supplements? I suppose this has been something that the researchers have failed on. Why so many supplements, and why, and who is saying these supplements should be given? So how the research should aim at how to educate mothers to learn that milk is adapted and therefore those supplements are not needed. I don't know if this answers your question, and also I would unify a survey, because nowadays at a national level, there are not official data on exclusively breastfeeding houses. There's no official paper. What we hear about is what is done in every hospital. It's a large study, but these should be official data. I would suggest that they should research on an survey that should be well recognized and undertaken, and something maybe doesn't adapt to all hospitals or all environments. So with our studies, I think the future investigation should be along those lines. I don't know if this answers your question. Yes, perfectly. Thank you. And I have a question for Irene, and I promise I will not ask any more. I don't know, maybe this wasn't clear enough to me, but could you explain, please? I understood that there was no effect because of having the delivery plan defined, but I understand that labor plans could be very difficult. The choice the mother makes would be very different. So I don't know how that non-difference in neonatal results would be having or not having the labor plans, or maybe because the labor plans could be very different. I don't know. Maybe there have been no differences found. Thank you for your question. Very interesting. We, by chance, presenting the labor plan, the number is very low, those who presented. So what was distributed was a standard. In this case, we have one by the ministry, which responds to evidence. I mean, it's nothing. Although there's a part concerning special needs in which the mothers can specify something more specific, it is true that we have not found anything else beyond what has the check marks that had to be covered in this research. But concerning future research, the question should be of those, how many are being observed? Because this is just, are they informed or not? Are they presented or not? But we would still need a further investigation to see the level of compliance of those documents. That would be enough for another PhD dissertation. In this case, 350 women should be studied one by one and checking item by item what they check, what they haven't, or if they should include something that's not been considered. How much of it is actually, in fact, taken into account? Do you intend to do that? No post-doc studies, no. No, we are focusing more on a qualitative approach because the PhD focuses more on satisfaction. And since the satisfaction perinatal results already rendered enough results, so we did not continue with the qualitative analysis of satisfaction, which was something that we realized that many women said as a comment, and you could include some information that we had in the dissertation, but as an anecdote, not as a qualitative analysis or a methodology. Well, you should encourage the team or other young people. Yes, the next PhD student. Yes, there is very much to analyze here and to cover in further depth. And I think when there, especially if you're interested in implementing these labor or childbirth plans and knowing very well, yes, and the autonomy of the woman and the decisions taken, which showed very interesting results that we discussed. Yes, thank you. Thank you very much. I will not ask anymore. I don't know if Silvia has any questions.
Más que una pregunta, es quizás un comentario también siguiendo el hilo que hablabas antes. Espérate. Con María Pilar también. sobre la satisfacción de las madres, ¿no? Y es que yo me había notado aquí, que me ha llamado la atención, ¿no? Que quizás la satisfacción más baja es justamente lo que comentabas, ¿no? En las medidas de identificar o cómo identificar que el bebé pues, se queda satisfecho o que tiene hambre, ¿no? Que va muy en la línea de que quiero un suplemento y porque mi bebé tiene hambre y tal, ¿no? Y luego también me ha llamado mucho la atención el tema del perfil, el perfil de la mujer que en principio está menos satisfecha, ¿no? Que es un perfil de mayor edad y en principio con mayor formación, ¿no? o mayor formación académica, digamos, ¿no? Formación universitaria. Y no sé si todo ello me lleva a pensar que quizás tenemos que ir en esta línea, ¿no? De decir qué perfil tenemos delante, ¿no? A quién nos enfrentamos o a quién atendemos y cuáles son las necesidades más percibidas, ¿no? Y por qué se genera esa insatisfacción o ese nivel de satisfacción más bajo, ¿no? Es encadenar un poquito la línea que tú ya habías apuntado y que ya apuntaba también Esther.
Estoy de acuerdo contigo, Silvia.
I agree, Silvia. I think there's very much to research in that field. And again, we go back to the same thing. We are not used to personalize the care so much depending on who we have in front of us. It's not the same thing to have a woman age 40 than an immigrant of 18. The two will not have the same needs. And nowadays, it is very difficult to personalize the needs. So I think that's why we see such great differences. I agree with you. Can't say anything else. I think it's a very interesting study with the surveys, with the diversity of the hospitals that have participated. Some hospitals with 120 beds and others like Vallebrón Hospital, and each one should organize their data and could draw their own conclusions. But there is nothing official, and the survey is complicated enough for small hospitals or other hospitals. So every hospital should have a closer look at the questions or those who don't see their expectations satisfied. And from that survey, analyzing those results in every hospital could improve in the sense of what the patients refer, which could be very different. Some hospitals have many immigrants and others don't have many immigrants. I don't know if that would be determinant. Yes, it is interesting, right? When we speak more of personalizing care, we are apparently standardizing more. That's my humble opinion. We're standardizing too much, perhaps because of lack of time or because it's more convenient or because we haven't considered the needs of these people. And a line of research that I've not found very much is why isn't this done in the cases of C-section? In some cases, women undergoing C-section have demanded that. They have. Very interesting. Thank you. Thank you. Sorry, I was muted. I believe it's 8 o'clock. It's time to finish our session for today. I want to thank the participants for bearing with our difficulties having done this online. I want to thank everyone who have started and continued all the way through in the session, although it is so very late. And I hope you rest well, and I hope you connect to us again tomorrow. As you will see, as you've seen with our different sessions and symposia and papers. And I hope you join us after a good night's rest. Thank you. Goodbye. Thank you, Esther. Thank you. Thank you very much. Bye.
Hasta luego.
Gracias, adiós.
Adiós.
Muchísimas gracias.
Gracias.
Thank you very much. Thank you.
Muchas gracias.
Goodbye.